Welcome to the deep dive. Today, we're really getting into something quite revolutionary in reproductive medicine, the frozen embryo transfer, or FET.
That's right. Most people might picture IVF and think immediately of, well, a fresh transfer happening right after the eggs are retrieved. But these days, thanks to some amazing cryopreservation methods, freezing embryos is often the way to go. Sometimes it's even required.
Exactly. So our mission today is really to unpack this for you. We want to look at the big strategic advantages of freezing, thinking about safety, flexibility, and then we'll jump into the science. I mean, how does an embryo actually survive being flash frozen to almost minus 200 degrees Celsius? It's pretty incredible. And we'll definitely cover the success rates, what the numbers look like, and why timing is so critical in a frozen cycle.
Yeah, we should probably name the star player right up front. Vitrification. This isn't like your standard freezer. It's an ultra-rapid freezing, a flash freeze, really. And it's basically solved the old problems with freezing things, unlocking way better success rates, and just more options for patients everywhere.
Okay, so let's start unpacking that powerful why. The sources really seem to push for freezing over the immediate fresh transfer. What's the biggest sort of strategic gain here? Why wait?
I think the single biggest advantage is splitting things up. You separate the egg retrieval cycle, which involves a lot of hormones, from the actual embryo transfer attempt. See, when a patient goes through ovarian stimulation, their hormone levels, they're artificially really high.
Right.
Freezing lets the bodies, specifically the uterus, just settle down, recover fully. It creates a much calmer, more receptive environment for the embryo later on. So this pause, it lets doctors really nail what we call better timing for implantation.
So you're taking out all that hormonal noise from the stimulation phase.
Okay.
But thinking beyond just getting the uterus ready, is there a big medical reason to go for a full freeze-all?
Oh, definitely. That really comes down to safety,
Mhm.
especially for patients we call high responders, those who produce a lot of eggs during stimulation.
Oh, okay.
They are at a real risk of developing something called ovarian hyperstimulation syndrome, or OHSS.
And that's serious.
It can be, yes. It's not just feeling bloated. OHSS can involve fluid shifts, real discomfort, even potential risks to, major organs. It needs to be managed carefully.
Wow, okay.
The thing is, the hormone spike that comes with an immediate fresh transfer, and then the hormone rise if pregnancy starts, that can actually trigger OHSS or make it much worse. So by choosing to freeze all the embryos, a freeze-all cycle, and skipping that fresh transfer altogether, we dramatically cut that risk. Patient health comes first. It's a crucial safety step.
That really changes the perspective, doesn't it? It's not just convenience, it's a necessary medical strategy sometimes. And thinking about the whole IVF journey, freezing those extra embryos must be a huge efficiency boost, too.
Oh, absolutely. It makes future attempts much simpler. Let's face it, the ovarian stimulation and the egg retrieval, that's the toughest part physically.
Yeah.
So if you get good quality embryos you don't use right away, you can store them, maybe for siblings, years later.
Yeah.
It means you don't have to go through all the hormone injections and the procedures again and again. That saves a huge amount of physical strain, emotional effort, and, frankly, cost.
It's like a biological time capsule, really, offering that long-term planning, whether someone needs fertility preservation before, say, cancer treatment, or just wants to space out their kids.
Exactly. It buys you time. And in fertility, time can be everything.
But, okay, none of this amazing flexibility works if the embryo doesn't survive that extreme cold. We've covered the why, safety, timing. Let's get into the how. How does it work? What was the big problem scientists faced?
The fundamental problem with freezing any living cell, really, is the water inside it.
Water.
Yeah, water. If you freeze it slowly, it expands and forms sharp ice crystals. Think of them like tiny daggers inside the cell. They just shred everything. Cell membranes, important structures, even the DNA. Really damaging.
Okay, so ice crystals are the enemy. How does vitrification get around that? It's not just freezing fast, is it? There must be more to it.
It's less like freezing and more like turning the cell into glass.
Yeah.
Instantly. Vitrification is this process of super rapid solidification. Instead of water having time to form those damaging crystals, it's cooled incredibly fast. We're talking about plunging the embryo into liquid nitrogen.
Liquid nitrogen. Wow.
Yeah, at minus 196 degrees Celsius. The whole structure just solidifies instantly. into a glass-like state. It completely bypasses that crystal-forming danger zone.
Minus 196. That's just mind-bogglingly cold. But surely you don't just drop the embryo straight into that. It needs some kind of protection.
Oh, absolutely not. No, they get pre-treated. There are these special things called cryoprotectants.
Cryoprotectants, like antifreeze.
It's exactly like a medical grade, super effective antifreeze. They do two main things. First, they pull water out of the cells, dehydrating the embryo, which is good, gets rid of the potential ice. Second, they actually go into the cells and replace the water molecules. Substances like ethylene glycol, often they act like internal shields, protecting all the important bits, the cell machinery, during that super fast freeze.
Got it. So the cryoprotectants are the shields, pulling water out and protecting what's left, and then the ultra-fast cooling locks it all down before crystals can form. That's really clever.
It is quite ingenious, yeah.
Does this work equally well for all embryos? Or is some better suited to handle this?
Quality definitely matters. And maturity. We find that embryos frozen at the blastocyst stage, that's usually day 5 or day 6 of development.
Yeah.
When the embryo has already started to differentiate into different cell types, they are significantly more robust. They handle the freeze-thaw process much better. Their survival rates after thawing are really high. We typically see, 90 to 95% survival, which is much better than embryos frozen at earlier stages.
90 to 95%. That's incredibly high. That must be very reassuring for people going through this.
Okay.
Okay, let's switch gears then to the bottom line. Success rates. If someone uses a frozen embryo, what kind of pregnancy success can they realistically expect?
Well, this is where it gets really interesting. The data consistently shows that FET cycles have success rates that are, well, right up there with fresh transfers. Sometimes they're actually statistically better.
Better, really?
Yes, and again, it probably goes back to that strategic advantage we talked about, transferring a healthy embryo into a uterus that's had time to recover and is optimally prepared. It just seems to work extremely well.
Right, the calmer environment. Now, here's a question that comes up a lot. Age. If an embryo was created when the woman was, say, 30, but she doesn't transfer it until she's 40, which age counts for success rates?
Ah, that's a crucial point. The success rate is overwhelmingly tied to the woman's age when the eggs or embryos were originally created and frozen.
So you freeze time, essentially.
You effectively do. You're freezing that biological potential. The embryo's quality, especially its chromosomal health, doesn't degrade in storage. So for women who are under 35 when they froze their embryos, the live birth rate per transfer is strong, often in that 40 to 60% range.
Okay, that's significant. But it still reflects the reality that egg quality declines with age at the time of retrieval, right?
Absolutely. So if a woman was, say, 38 to 40 when her eggs were retrieved and embryos created, those live birth rates per transfer are typically lower, maybe 20 to 30%. That's true even if the embryo has been stored for years. The starting quality determined by age at retrieval is the key factor.
Makes sense. Okay, the other big variable with FET is preparing the uterus. Since you've separated the transfer from the natural cycle hormones, doctors have to kind of orchestrate the environment. How do they do that? You use the analogy of preparing soil for a seed earlier.
That's exactly it. The main goal is to build up a nice, thick uterine lining, the endometrium, usually aiming for somewhere between 7 and 12 millimeters thick. Doctors manage this very carefully with hormones. Typically, they'll use estrogen first that helps thicken the lining. Then, at the right time, they introduce progesterone. Progesterone is the signal that tells the uterus, okay, get ready, become receptive. It opens that crucial window for implantation.
And the sources mention two main ways to handle this hormone prep: a medicated cycle and a natural cycle FET. What's the difference there?
So the medicated cycle FET gives the most control. You use external estrogen and progesterone, basically overriding the body's own cycle. This lets the clinic time the transfer very precisely. It's great for women with irregular cycles or, if predictability is really important for scheduling.
Maximum control. And the natural cycle.
The natural cycle FET, as the name suggests, uses fewer drugs. It basically tracks the woman's natural cycle, monitoring her hormone levels. The transfer timing is based on when she naturally ovulates. It does mean more monitoring, more blood tests, more scans, but some patients prefer it because it involves less medication.
And both work well.
Both can be very successful. The choice often depends on the patient's specific situation and preferences and the clinic's protocols.
We should also touch on genetic testing. Freezing seems almost essential if patients choose pre-implantation genetic testing, or PGT.
Oh, absolutely critical. PGT involves taking a tiny biopsy, just a few cells, from the embryo, usually around day 5 or 6.
Right.
Those cells are sent off to a lab to check for chromosomal abnormalities. And getting those results back, it takes time, days, sometimes even a week or two.
You couldn't do a fresh transfer then.
Exactly. There's just no way to wait that long and still do a fresh transfer within the right window. So, freezing the embryos is standard practice for PGT. It gives the time needed to get the results, select the chromosomally normal embryos, and then prepare for the transfer. This can significantly reduce miscarriage risk and boost the chances of a live birth.
So the delay becomes a tool, really.
Precisely. A vital tool for embryo selection.
Okay, let's zoom out a bit to the bigger picture. Storage, how long things last, and maybe some of the complexities. We talk about freezing for years. How long can these embryos actually stay viable?
Almost indefinitely, theoretically. Once they're properly stored in liquid nitrogen at that -196 degrees C, all biological activity just stops. Metabolism halts. The current published record for the longest storage that resulted in a successful birth is, well, it's pretty amazing. It's 30 years.
30 years, that's incredible. It really speaks to how good vitrification is. What about keeping them safe? Making sure the right embryo goes to the right person and that the storage tanks are secure?
Oh, the logistics and safety protocols are extremely strict. Clinics take this incredibly seriously. Every single straw containing an embryo gets a unique barcode or ID code. They use double witnessing systems for everything. Meaning 2 different staff members have to independently check and verify the identity at every single step. Freezing, thawing, transferring. It's designed to prevent any possible mix-ups.
Okay.
And the storage tanks themselves, they're under 24/7 monitoring. Alarms, backup systems, checks on liquid nitrogen levels.
Yeah.
Everything to make sure that temperature stays constant and viability isn't compromised.
That level of detail is definitely good to hear, but let's keep it balanced. The science is amazing, but what are the potential downsides or limitations people should be aware of?
Well, firstly, while the thaw survival rate is excellent, like we said, 90–95% for blastocysts, it's not 100%. A small percentage of embryos, unfortunately, just don't survive the thawing process.
Right. That's a risk.
And then there's the cost. Storing embryos isn't free. There are annual storage fees, and these typically range from, say, $300 to maybe $800 per year. If you're storing embryos for 5, 10, 20 years, that adds up. It's a long-term financial commitment people need to factor in.
That ongoing cost definitely highlights the ethical and legal questions that must come up with long-term storage.
It really does. Patients face some deeply personal, sometimes very difficult decisions about what happens to any unused embryos. Do they keep storing them indefinitely? Donate them to another couple, donate them for research, or choose disposal. And these decisions become even more complex over time, especially as circumstances change like divorce or, sadly, death. Clear agreements need to be made up front, but it's still a heavy emotional aspect for many people.
Yeah, the science gives us these incredible options, but it doesn't give us easy answers to those profound human questions about long-term responsibility. Okay, so to quickly recap our deep dive today, freezing embryos, particularly with vitrification, is a safe and highly effective technique. We're seeing 90–95% survival rates post-thaw for good quality blastocysts.
And it offers huge advantages in terms of timing, flexibility, and safety, especially in avoiding OHSS.
That ability to separate the stimulation phase from the transfer phase seems to be the key reason why frozen transfers often yield such great, sometimes even better results compared to fresh transfers.
It really allows for optimizing that uterine environment, which pays off.
It truly feels like a cornerstone of modern IVF. Now, as we usually do, we want to leave you with a final thought, something to chew on. Given that this technology allows embryos to potentially remain viable for longer than the relationship that created them, maybe even longer than the intended parent's lifespan, how do we, as a society, and how do clinics and families need to think about informed consent and long-term storage agreements for the next 50 years of this reality?
That's a really complex question, and one that ethicists, lawyers, and doctors are constantly grappling with. No easy answers there.
Indeed. And on that note, we'll wrap up our deep dive on frozen embryos in IVF. Just a reminder, this discussion was purely for educational and informational purposes. It is not professional medical advice.
Please always consult with your own doctor or a qualified healthcare provider for any personal medical advice or treatment decisions.
Absolutely.
And if you're looking for more information about the entire in vitro fertilization process, you can find lots of educational resources over at ivfforme.com.
Thanks for joining us. We'll catch you next time for another deep dive.